Okay.
Okay, great. Good afternoon, everybody. I am Jeb Bradley from Senate District 3. Today we are holding a meeting of the Senate Health and Human Services Committee to hear a briefing from the Department of Health and Human Services. We will take no action on any pending legislation for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us or call 603-271-6931. If the event the public is in the event the public is unable to access the meeting, it will be adjourned and rescheduled. 5, please note all votes taken during this meeting shall be done by roll call vote. And 6, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during the meeting, which is required under the right to know law. So we'll start with Senator Gray.
This is James Gray. I'm in my home in District 6, and currently I'm alone in this room.
Senator Whitley.
Good afternoon. This is Senator Becky Whitley. I'm in my home in Hopkinton, and I'm alone in the room, but my family is in the house.
Senator Avard.
Senator Avard here in Nashua in my office, and I'm alone in the house with a couple of puppies.
And I'm Jeb Bradley. I am in Wolfboro in my office, and I am alone. So,
Oops.
now, oh, I'm sorry, Senator Sherman. I thought I had hit you.
Thank you, Senator Bradley. I'm Senator Tom Sherman, District 24. I'm at my home in Rye, and my family's in the house, but I'm alone in the room. And as I just wanted to mention really briefly, unfortunately, I had a previously scheduled meeting at 1:30. I will stay as long as I possibly can today, but I may have to drop off.
Great. So the purpose of today's meeting is to hear a presentation on mental health and the so-called ER boarding crisis. I have asked the Department of Health and Human Services to have some of their top people brief the committee. And I know that Katya Fox, the Director of Behavioral Services, will start us off, but also joining us are Julianne Carbon, Erica Ungarelli, Henry Lipman, Heather Moquin, and Melissa St. Cyr. So, Kirsten, if you can bring those folks in, starting with Katya, that'd be great.
Katja, you should be unmuted.
Okay, great. So I'm not sure if I'm on camera.
You're not on camera, but we can hear you.
Okay, I don't know if there's something I need to do on my end, but if not, thank you very much for this opportunity. We're hot off the heels of doing the exact same presentation to Governor and Council at their request a couple of weeks ago. So rather than try to do a whole new presentation, you're going to see what we presented to them this morning. And we are going to have Heather Moquin as CEO of New Hampshire Hospital, the PATH program, as well as Glencliff. She is going to start us off. So if you could bring her in. And we also would like to share our screen because we did prepare the presentation. I think it'll be really helpful as we talk about the statistics of what we're experiencing.
That'd be great. Thank you, Katya.
Hello, Senators. Can you hear me? This is Heather.
Yep. Good afternoon, Heather. How are you?
I'm good. Thank you so much. I'm hoping that Joe Caristi, I think he's in the room somewhere waiting. If you could bring him in and allow him to share his screen, we do have a PowerPoint presentation that we could use.
I'm sorry, what was the name again?
Joe Caristi.
Sure.
Thank you.
There we go.
All right, now get you
Permission to share your screens.
And Katya, we can see you now. I don't know what you did to your.
Yes, yes, I turned on my camera and I think that Kirsten did some magic too.
Oh, good. Good work.
There you go.
There's
Now we see
Joe.
Joe. How are
Oh, there
you?
we go.
Hi, everybody. Good afternoon. All right.
All right.
Go ahead.
I am just pulling it up right now.
Okay, great.
So while Joe's doing that, I'll just go over sort of the agenda of the slide deck that we have here. So we're going to talk about adult emergency room boarding. We're going to talk about a review of children's emergency room boarding. There it is. A brief history of the mental health system in New Hampshire. And then a summary of everything that we're working on, really, to try to bring improvements to the system. So I will start the presentation, then at a certain point, Katja will take over with the discussion of a set of slides. Okay. So this slide shows referrals to New Hampshire Hospital. So you can see that it's fairly flat over the years from 2017 to 2021. When you look at this, it's also important to remember that these are total referrals, meaning total IEA referrals. So some of these folks didn't come to New Hampshire Hospital. Many of them went to DRFs, but this is the total volume of referrals in the emergency rooms. This slide shows our wait list. So number of patients in emergency rooms on a given day. So you can see that although the referrals have been flat, there's been a steady climb in the wait list, especially during the pandemic. If you look at the area of, let me just see, February, March, Joe's showing you there. You see that increase. That represents when we converted some beds, 10 beds, to child beds on one of our units. So we had a bit of a climb at that point before we stabilized again. Today's wait list number is 42. The last number you see on there is 45, so 42 today. This slide shows our daily census. And I thought that this was a great slide for you to see because we get a lot of questions about capacity here at the hospital. So you can see that, and I'm trying to look at the dates here. You can see that, again, the demand has been steady throughout the pandemic, but we've had some dips in census. Those really represent times when we had units in quarantine. So we were lucky early in the pandemic, and by early, I mean March, really through the summer of 2020. We got into the fall, that fall surge that all of us experienced here in the state, that was when we saw an impact here at New Hampshire Hospital. So we had a number of units on quarantine. We had some COVID positive patients. We had some COVID positive staff. So there were staffing issues at times also that impacted our ability to have beds operational. So again, this really demonstrates the impact of COVID on adults at New Hampshire Hospital. And again, it's not shown on this slide, but we know anecdotally that the DRFs also reported out the same situation throughout the fall and the winter where they had impacts. And you may have heard that also, that there were times when certain DRFs had to be closed because of outbreaks on their units or staffing constraints. This slide shows patients that are currently waiting for discharge at New Hampshire Hospital. So all of these patients that you're looking at, it identifies the housing or the discharge that they're waiting for. It's important to note that all of these people are not certified as needing acute hospital level of care. So you can see 18 are waiting for transitional housing, 12 for a nursing home, assisted living, 9, independent housing, 6, supported residential, 4, and then 3 and 1 based on some folks who struggle with developmental disability, co-occurring with mental illness, and then there's 1 that doesn't have a discharge placement identified. So this isn't a new problem. Unfortunately, this is the sort of that backdoor problem that we've talked about trying to overcome. So if you look at the total, my math is bad, but you could see that opening up these beds would essentially eliminate the wait list for adults. So again, thinking about capacity, we get a lot of questions about, you know, what's available, what's the capacity of the system. So this table lists by facility the number of beds that are available. So right now at New Hampshire Hospital, it's 165 for adults, it's 10 for children, again, temporarily trying to offset that huge surge that we saw in children waiting. But Hampstead Hospital has 15 adult beds and 45 child beds. The DRFs represent 60 beds, and then voluntary beds are 163.
Heather, can I just ask a question about that previous slide?
Sure.
Sorry to interrupt. So on the Hampstead number, is that the current capacity or what will be sort of the eventual capacity once their workforce issues are resolved?
I believe that's current, Joe. Am I correct? Current.
Correct.
And what will be the capacity once they are fully up and running?
It'll be at about +7 beds, 7 to 8. Yep. So their provider that's out on leave right now is returning the first week in May. So when she comes back, that census should increase.
Great, thank you.
Yep. So this is just a summary of what we just went through with inpatient psychiatry, that the referrals are steady. Capacity has fluctuated due to the pandemic. I think it's important to know that we're running at our highest census ever since deinstitutionalization of the campus, and that we continue to struggle with discharging patients to the community. So moving on to children, it's a bit of a different story for kids. So these are children waiting, ED boarding for kids. So there's a little bit of a gap in the data. That was when we transitioned and fully executed the contract with Hampstead Hospital, but then our data picks up and you can see this huge climb, at the peak of which I think you all are aware of when we hit 49 children waiting. The last data point listed is 35. That references the week of March 21st. Today's waitlist, though, is 5.
And what's different in the last, be about 3 weeks?
Great question. Katja, you want to answer that one?
Sure. And Erica and I spoke about this morning when she texted me and said, hey, the wait list is way down. First of all, I want to recognize that for those 5 families and those 5 children, that is still a significant issue. So while we can say, great, it's down, we still have those families and those children to consider. We believe that there are a number of factors, so we can't point to any one. First of all, we have schools reopening, and we think that that has an impact in helping create stability for children. Secondly, there has been increased attention thanks to all of you and everyone across the state who's recognized that this is an area that needs intense focus. So we think just by raising it as an issue that it's people are responding and acting in different ways. And 3, our interventions are working. And so the start of the implementation of the system of care is taking hold. We've increased our ability to provide fast forward wraparound services. And we are continuing to work with our providers. They're on the front lines and they're doing everything they can. And so I think those factors there are probably others, but those are the ones that contribute significantly to this. And again, we don't want to claim victory. We don't want to get excited. It's a point in time number, but we're hoping that maintains and continues to go down to get to 0.
Great. Thank you.
Thank you. One other note I think is just striking about this slide is just how clear the impact of the pandemic is. I mean, when you look back to 2018, you know, there were a few points where the wait list sort of peaked, you know, in the teens, but most generally it's been under 10 since 2018. So it's just really incredible to see the number of referrals for children.
And I also just wanted to add, Heather, the gap in the data for the transition to Hampstead, we were receiving waitlist reports from Hampstead. It was just faxes at that point in time. So I don't have a great way of summarizing it or an easy way to summarize it. But during that period, the waitlist was consistently less than 5. I think it was honestly very close to 0 on most days. So just wanted to share that tidbit that we were monitoring it during that period. We just don't have it in a format that's really easy to summarize.
Thanks, Joe. And what I remember about that point in time as well is that was the point where we swiftly, you know, we had the contract in place, but we had planned to have this transition happen sort of by attrition. We were children that were here were going to remain here until they discharged, but because of really the concern about COVID patients in emergency rooms, we transferred children to Hampstead. They continued, as Joe said, to send us, you know, the fax waitlist reports, but it was very flat at that point when we first initiated that. So again, this slide shows referrals. So not the waitlist, but the number of referrals. Again, steady climb. So in summary, again, pandemic has had this huge effect on the mental health of children, resulting in increased demands. Hampstead is fulfilling the commitments of their contract, but the demand for services is really unprecedented. And we have temporarily repurposed the 10 adult beds here at New Hampshire Hospital. We did that on February 20th and have maintained that census of 10 since then for pediatric care. So how did we get here? So this is some of the historical, just briefly, these decreases in capacity. Our slide here references the closing of the Children's Hospital, the Philbrook Center, in 2010. But Katja mentioned during our early presentation that actually these reductions in services occurred in the context of the recession in 2008. There were also reductions in DRF beds. There were reductions in community-based residential services like group homes. But since then, there's been consistent demand, less capacity. Referrals for adults remain consistent. And pre-pandemic, referrals for children were consistent also. And again, the increase in demand is with children during the pandemic. So we thought we'd talk a little bit about some things that we've been working on. So, you know, here at New Hampshire Hospital and with the department, we executed that Hampstead contract for child inpatient psychiatry. The idea behind that was that we would sort of backfill or reclaim those lost beds from 2010 and increase census. We have done that partially. We've gone from 165 to 175. We opened the PATH Center, which is our transitional housing center here on campus. We opened that in September 2020, and that census capacity is 16. We've also partnered with Oceanside Nursing Home, a Genesis Nursing Home in Hampton, New Hampshire. They are opening a long-term geriatric specialty psychiatry unit for long-term care of patients. We think that that's going to be a huge help for us. And by partnered, we're not contracting with Oceanside or anything like that, but we're working really closely with them on developing programming, helping them talk about, you know, treatment modalities, connecting them with providers in the CMHC. And when they do open and take some of our patients here from New Hampshire Hospital, our psychiatry department is going to be very connected with them, warm handoff, ongoing teaching, and really ongoing communication to try to prevent rehospitalization. But certainly if a patient needs to come back to New Hampshire Hospital, we will do that quickly and support their program. in process. We're renovating that former children's unit, again, to convert all of those beds back to adult. We are improving our recruitment and retention rates. And pending after that renovation and additional recruitment, particularly of RNs, we will increase our census again and go to a maximum of 184.
At the New Hampshire Hospital.
Correct.
This is all the hospital. Okay.
Yep. Yep.
So I'm going to take over.
Is any of that, I'm sorry, Senator Sherman, is any of that at Fruit Street, or is that all at the hospital?
That's all at the hospital.
Okay.
So I'm going to pick up from here, and these are very high level bullets. So if you have specific questions, that would be, we'll be able to respond to those. But what I should say is that what are we doing about it? Well, we've been working since we established, our real focal point in our strategy is detailed in the 10-year plan for mental health, as well as in Senate Bill 14, which is the system of care. And so since 2019, those have been established, and we've been working very hard to implement the components of that, mostly because we've had the funding available. And that's been a real great infusion to be able to get things moving. And so while it may not be as readily apparent to the general public about the work that's been done, a lot of the work is building blocks to fulfilling the dreams, so to speak, and the reality of the 10-year plan and the system of care. So we've been building new care delivery models. One example of that is the creation of statewide mobile crisis for adults and children. And that is in process. There'll be contracts that will be forthcoming before Governor and Council in the next couple of months. All of that work is work that we do every single day. The pediatric behavioral health training is happening. We are creating new levels of care, and this really speaks to the residential care for children. And so we have the different levels of care that have been put out for procurement. We received a very robust number of responses, and the review team had to go over 40 proposals to address those models of care. So we're really excited about getting that response from the community. And again, that is in process, and we're in negotiations and discussions, and those contracts will be forthcoming in the next couple of months. And then we have stood up beds, and we will continue to move to stand up beds for the adult population. So there have been additional designated receiving facility beds, transitional housing, and peer support respite. That's an area that is very important as we look at interventions that can happen before anyone hits the hospital. So all of these are really intended to serve people in the community rather than having to serve them in acute settings. One of the areas that has come up around, well, I'll get to that in the next slide actually. So this one, I think this committee is very aware of the Children's Behavioral Health System of Care. And just as a reminder that we didn't have a Bureau for Children's Behavioral Health 5 years ago. And the last 10-year plan, which was 2008, did not address children. And so we made sure that that was front and center with this newly established 10-year plan. And when we were talking about putting together the slide about the loss of services, and when we started thinking about it, we realized that it was hard to lose services that didn't exist when it came to children. That really we did not have the system that we envision and we believe is necessary to address the needs of children and their families. And so those, the services that were in place were mostly served by DCYF. So a family and children had to come in through that lens and through that system rather than being afforded the opportunity through a behavioral health lens. And so what else are we doing? We have created value-based arrangements with managed care organizations. Henry Littman is available if we have any questions about that. We're reviewing the payment rates for housing. We heard from the community mental health centers that the reason why that they're not bidding on the housing, transitional housing that we have put out procurements for is because of those rates. And so we're working with the commissioner and with Henry's team on looking at what it would take to be able to raise those rates. And so that's something that we want to achieve because we do realize that that is necessary in order to have this robust housing continuum of care. So we have looked at contracting with facilities close to the state lines. So knowing that Brattleboro Retreat is not very far away, we've had conversations with them as well as other providers in other neighboring states. There's a children's pilot of intensive in-home supports, and we're working with the MCOs on that and hospitals as well. Just a note that the check mark should be on the bottom bullet in reverse of the other one. So CMHC financial relief and CEO contract, that was something that we heard loud and clear that was needed. There is a maintenance of effort in the contracts that the MCOs have with the community mental health centers. And so that was lifted during the public health emergency. And then we have the recent report that was issued by the consultants Alvarez and Marcel that really called out the fact that we needed an Institute for Mental Disease waiver from the federal government, which is a waiver of the requirement that there be 16 or less beds in order to receive Medicaid reimbursement. And so this would allow for there to be facilities that have more than that, including New Hampshire Hospital, to be able to bill Medicaid for a period, I believe, of 30 days. So the idea is still not to unnecessarily have people in such facilities, but to be able to leverage Medicaid reimbursement for those that need it.
And I just wanted to add there to the check mark and the in-process box on those bottom two are actually fixed. They were backwards this morning during our GNC presentation, and I fixed them before this one. So I apologize for that. I should have let Katya know that.
Thank you, Jeff. And then this is just getting involved. So I asked the council this morning to be aware that the contracts would be forthcoming. And we're asking you, and I think that all of you already do this, but just a reminder that we want providers in your communities to respond to RFPs. And we're trying to really adjust to the situations that we're hearing about so that we can make it more enticing for providers to do that. And then, of course, looking at those providers in your districts, in your catchment areas, who may not already be providing behavioral health services to come on board. And then in summary, we know it remains a challenge and that we need change. And this is not a state issue. This is not a hospital issue. This is not a CMHC issue. This is something that's really across the board, all of us. And we all have to remain vigilant and all hands on deck for the foreseeable future to address this issue.
Okay, thank you, Katya, very much. I indicated to Senator Sherman he'd get the first crack at questions because he has a shorter time commitment than the rest of us. So Tom, go ahead.
Thank you, Senator Bradley, and thank you all for this great presentation. I think there's some optimism in there. I find it frustrating that I understand there was potentially more than $10 million that did lapse. So my first question would be, assuming SB 157, I think it's Senator Whitley's bill, passes, which does not allow the remainder to lapse, are you going to have enough funding to complete the work that was envisioned by SB 11 and SB 14 for the systems of care and for all of the intervention teams, the mobile crisis teams?
Simple answer, yes. And we very much appreciate the support that has been given to that bill.
Great. Follow-up?
Yep, go ahead.
Second is, you talked about optimizing reimbursement through Medicaid for hospital stays. One of the areas which you may or may not know, Katja, I think you were involved in this at the beginning. Senator Bradley, Senator Whitley, and I have been working with the Department of Insurance, the governor's office, to make sure the commercial carriers are pulling their weight. And we've really found some interesting speed bumps along the way. The fact that they don't credential bachelor's level providers, they don't credential facilities, but only providers. So it leaves an awful lot of services unreimbursed, both in our CMHCs and also that's provided in the hospitals that do participate. And so a question I have, is there any reimbursement by commercial carriers for the hospitalizations that take place either at Hampstead or at New Hampshire Hospital?
I can actually take that question. And just for context, I'm Joe Christie, the CFO for New Hampshire Hospital. And so the short answer is yes. We actually do have a contract at New Hampshire Hospital with Blue Cross Blue Shield. I'm actively working with Chris Nicolopoulos over at the Insurance Commission on getting contracts with the other commercial carriers. Historically, that has been a real challenge to lock those contracts in. We've been negotiating with some of them. I've been here 2 years and we've been negotiating for 2 years. But I actually think we're getting much closer, and I'm hopeful in I would say the next two months or so, we will have contracts with Cigna and then Optum, who now administers for Harvard Pilgrim, United Healthcare, and Tufts as well. And so that will actually be a big leap forward. And I know they do have contracts with some of the DRFs and voluntary hospital beds as well.
One more, or
Yeah, go ahead.
Thank you. That's really great information. And I just let you know that we're here to support you. 2 years is an awful long time with all these people waiting in the emergency rooms and with the state having to pay the bill, the state and the feds, but mainly the state. So I really applaud that effort. Another area that we discovered is that in the emergency rooms, when a child is boarding, only providers who've been privileged by the hospital are allowed to come in and see that child. So even if there is our wraparound or functional services that would be available for that child, they can't come into the hospital. And I was wondering if any of you have reached out to the hospitals or would, we have certain hospitals we can reach out to, but this is pretty much across the state, that they're, at least while people are boarding, adults and children, they need to make it possible for the CMHC teams to come in and be able to provide full service while the person is sitting in the emergency room. The restrictions really don't fit for the needs of the patients who are stuck in the emergency rooms. I'm wondering if there has been any recognition of that hurdle or whatever you want to call it. But it seems to me something that we should be able to overcome if we could work with all the hospitals to say we need emergency privileges for the facility to be able to come in and provide those services. Are you aware of that? And has there been any outreach to the hospital association or to the hospitals to facilitate full service in the emergency room while a patient, a child or an adult is waiting?
So Senator, yes, we are very much aware of that. That's been an ongoing issue that we've heard about and that we've made some efforts on. I believe there was some legislation and there's been a lot of activity and discussions. Those discussions are ongoing within Hampshire Hospital Association. And so what I would encourage is for you to speak directly to the president of the association, Steve Onen, who's been a great partner with us. And many of the hospitals are great partners and do allow those privileges. But I do understand that there are some exceptions to that.
Great. One last one, Senator Bradley, if I could.
Yep.
And I think this is for Katja, but on SB 11, Senator Bradley and I worked very closely on that along with Senator Feltus at the time. And transitional housing, there was funding for transitional housing in that. How much of that has actually been implemented and built and is now available?
So I'm going to ask if we could bring in Julianne Carbon, who is the Director of Mental Health Services. We did stand up some beds as a result of that legislation, but I would like her to be able to give more details on that.
Hello, can you hear me now?
We can. Good afternoon.
Fantastic. Thank you. So yes, there was funding included for an expansion of 40 additional transitional housing beds. And some of those beds were stood up through the PATH Center. So 16 of those beds were stood up as part of that project. And 2 additional beds went out through contract with NFI North. As I'm sure you're aware, we did release a procurement to expand those beds even further and did not receive any respondents. So for those particular services, that's where we're at in terms of that expansion.
And that circles right back to the discussion that we had about the reimbursement rates and something that we're pursuing right now.
Okay. That's frustrating to hear. Do you think we need to, is this going to need further legislation to make that shift in reimbursement rates, or is that something that we can do without legislation?
I think that's a further discussion with, as we move into the Senate phase of the budget. And also that I know Director Henry Lippman is working on finalizing those numbers. So we don't have the actual amount that we can detail right now, but we are looking at that, not only for the expansion of beds, but also for the reimbursement for the current beds that are provided by community mental health centers.
I have one last question, Senator Bradley. I'm so sorry.
Yeah, go ahead.
So the other area where we've been working very closely with the CMHCs, and we actually had a meeting with the Department of Insurance, is this issue of the insurance, the commercial carriers not credentialing facilities and not paying for bachelor's level services. It's incredibly frustrating because what ends up happening is the CMHCs, if you have private insurance, they end up covering it because it's the right thing to do and they don't get any reimbursement. So in essence, these services, which are state-of-the-art, top-level services that the state has embraced through Medicaid and are available to our Medicaid recipients, are either not available for our privately insured, or the people who provide it are just eating the cost because they know it's the right thing to do. is the department, we've been working on this, is the department aware of this issue and the lack of credentialing for bachelor's level providers for functional wraparound services?
So yes, of course, we're aware of it. It's my understanding that the governor sent out a letter asking for input and more information on that, and asking the providers specifically to detail those issues. And the association that represents all 10 community mental health centers did respond to that.
Great. All right. Thank you. With that, I'm going to have to jump
Okay.
over to my other Zoom. Thank you. And thank you guys so much. I'm sorry for the 20 questions there, but it's been really, really helpful.
We wouldn't
Thank you.
expect anything less.
Thank
Okay,
you.
so we have about 20 minutes left. I apologize for the short time frame, so I'll recognize other committee members for questions at this point. Senator Whitley.
Thank you, Senator Bradley, and thank you all to the folks here. This is something that I'm sure keeps a lot of people up at night. It's something that, as a mom, particularly all these children that are in ERs has kept me at night. The numbers just kept creeping up and creeping up and creeping up. And, the urgency that I think we all feel still hasn't gone away. The number is 5 today, and I was glad to see that. But the urgency remains, and this remains a crisis with a lot of barriers. And so, I'm thankful to you folks for, being at the table to be a big partner in eliminating these barriers. A lot of us have been in countless work groups and meetings related to the ER boarding crisis for years, right? And so I think there is a level of frustration for many folks, all different parties about, so why are we still here, right? And I share that frustration. We have hospitals at the table, we have private carriers at the table, of course, DHHS at the table, DOI, CMHCs, and other providers. And, a lot of times I'm happy that everyone is at the table, and I do commend folks for being committed to be at the table. But there does feel like there are times where folks are sort of looking across the table saying, well, this is someone else's responsibility. So I'm wondering, sort of my first question is, at the end of the day, what do I say to my constituents? Concord Hospital, of course, is in my district, and it is one of those places that has people in the hallways, both children and adults. What do I say to those folks? And what do I say to Concord Hospital about who is ultimately responsible for addressing this ER boarding crisis?
So I'm going to be provocative and ask you who you think is responsible.
It doesn't work. It doesn't work that way. Thanks, Katya.
Well, let me jump in then and rephrase the question. Hopefully the Senate's going to have the budget. We still have 2 or 3 months in the legislative session. Katya, what is it that we could do as members of the HHS committee, whether it's on credentialing, whether it's on providing resources for DRF or transitional housing or peer support, which I noted from one of your slides, were top priorities. What could we do for you? Do you like that question, Senator Whitley?
I don't, because here's why. Sorry. Here's the thing, I share this frustration because, as I've been on this, on both sides as an advocate and now as a legislator. And, in the last biennium, there was so much bipartisan support and solutions-oriented work in the legislature. Like, everyone came together. And we're now in a situation where this, of course, we know this has been exacerbated by the pandemic. I don't think anyone would disagree with that. But we're also in a situation where all this money was allocated. We had these solutions in place, but it just hasn't been implemented. And so you're hearing some of my frustration that, as a legislator, I don't know what else we can do, other than providing solutions and funding to sort of get this moving forward. And so maybe this is a more specific question. We heard that a lot of RFPs, many RFPs I can think of for transitional housing in particular, just don't go responded to. And this is something that I'm really concerned with as we're standing up access to statewide mobile crisis, which we know is a linchpin in resolving this. What are the department's plans about developing RFPs that are going to be attractive to providers?
So Senator, sorry for being flippant earlier. It's just that if it were just money, it would be fine. But you've already identified in just our brief discussion today, some and others have, the barriers. If you think about the housing market right now, it was bad before the pandemic. Now, to find housing, just to find a placement for a integrated setting with a housing bridge subsidy, it's very, very difficult. And so if we just assume that funding something fixes it, we're not going to ever get to where we need to be. What we need, and I think responding to Senator Bradley, is we need people to think differently. We need to reimagine, and that's exactly what the 10-year plan and what the system of care do. It's not about what more can we do, it's how can we do things differently that really speak to the needs of the communities and families, and most importantly, the individuals that we serve. And so that's what we really need. We really need to think about how this system, it wasn't working before the pandemic. It certainly isn't working now. The majority of people are being served and served very well. We're seeing with those wait lists, the ones that aren't and that are falling through the cracks. We haven't intervened early enough, and we don't have enough community-based services. So yes, money has been very helpful, and we are standing up those services, but you can't defund a system over 10 years since 2008, lose services, and expect that throwing money at it is going to build the system within a year. We need time. And we know that families don't have time. So we're trying to take those intermediary steps to address their individual needs while we're building and transforming this system. As you all know, the children's system didn't really exist. It existed through the DCYF process. We're building a system. That doesn't happen in a 2-year time frame. And it's extremely frustrating. It does keep us up at night. I'm trying to hold together my team because it's really, really difficult to be hammered on a daily basis and then have a personal reaction to the crisis that we know families are experiencing. So that's my response. We've told you some of the things that we're doing. We heard about the RFP and what's the problem is with transitional housing. We're working on it. We're going to be putting forth something. So we just can't expect a system to turn on a dime because we had a pandemic.
Thanks, Katya. And I really, if I may, a follow-up.
All right.
Bradley. And I appreciate that, systems change is slow and it requires, continued attention by everyone at the table. And I appreciate that. You mentioned the mobile crisis and sort of where we are on that, just sort of the timing is that, statewide mobile crisis for children was required in Senate Bill 14. That passed in June 2019. It was fully funded in the budget in September. And then, in DHHS's infinite wisdom, I was happy to see that, that was the opportunity to get statewide mobile crisis for adults also. And so we had heard previously, I think it was on the hearing for 157, that there was an RFP and a contract about to be awarded for this sort of centralized call center. So I'm wondering if you can give an update about that, and also an update about who is actually going to be providing the mobile crisis and when we can expect that to be stood up. And then just sort of this question about a conceptual question about mobile crisis. I think we heard last time that there was a thought that it was going to be provided regionally, and my understanding was that was by the CMHCs. And I'm wondering if there's any thought about, considering our sort of workforce issues. We know that we have a lot of workforce shortages, particularly in the mental health system. Whether a sort of, it makes sense to look at this in a different way, in possibly having one vendor.
Why don't we let
provide
her
local
answer, Senator Whitley, at this point, because we're short.
Thank you.
Okay, so number one, you asked about the centralized portal as called for in the 10-year plan. The negotiations are ongoing. It's a very complex RFP and a very complex application. So that is in the works, and we want to have that before Governor and Council as soon as possible. We have to rely on our legal team and our contracts team to take care of all of the due diligence that's needed for that. The concept is to have the delivery through the community mental health centers. We've been working with them on a daily basis to establish those teams. And we, at one point, were considering other options and gave them a deadline to indicate whether they were in or out. And all 10 committed to being in. And now we're again having those discussions about what that looks like for each of them. The workforce issue is, of course, something that we have to face. We have other programs that we want to implement, and we have current programs that across the board, everyone's struggling with workforce. We all know that. And when we, even in the department, we have openings, we have staff that we can fill those positions, and all we're doing is swapping players. We're not bringing in new players. So that's been really, really difficult, and I don't have a quick, concise response to that.
Okay, so we only have a couple of minutes left. Let me, without repeating my question, just open it up again to you, Katja, of what we can do over the next 2 or 3 months while we're in session, and we have the budget, presumably, to help in this process.
So thank you. So stay tuned on the discussion about raising those rates. So we'll have that information, and that will be forthcoming.
Or transitional housing.
Yeah, for transitional housing. Yeah, for community residents is the actual, I think, Medicaid bill term. I think that I need to bring it back, and all of us need to have a discussion about that, because there may be some opportunities around workforce. There may be some opportunities that are already either in the works through bills that you have and supporting those. For example, the carrying over and not having the funds lapse is one of them. But there are probably others, so we should confer and get back to you on that. But we really appreciate all of your support, and across the board, it's been very, very good.
Senator Bradley, sorry, this is Heather. Can I just add just
Sure.
a comment, just I think for you to keep in the back of your head as you move forward. We are concerned about positions and vacancies. So we are working really hard to fill vacancies, and we also want to and need to increase. I mentioned RN staffing in particular. To bring more of these beds online, we can't lose positions.
Got it.
It's so critical. And with the argument that we have heard is, they're vacant anyway, why would you need more? Well, we're filling our positions. It's taken us a while, but we are taking, such a broad approach and trying to be as innovative as we possibly can. We're all competing, right, for the same workforce, hospitals, mental health, but we're throwing everything we have at it. And this is a good place to work. We think we can get people here and hold on to them. So if we can hold on to positions, we really need it.
Okay, one last quick question. What kind of impact, I know it's a longer term impact, but if we proceed with the expansion or the change of the secure psychiatric unit, what would that have in terms of capacity at the hospital?
If the Forensic Hospital, we're 60 beds. That would open up a 24-bed admission unit here at New Hampshire Hospital. But if the Forensic Hospital is 24 or 25 beds, there's minimal impact to capacity here at the hospital, minimal to none, I would say. They would take that hospital would take a few of our referrals that we currently get from county jails. So civilly committed mentally ill folks, those referrals. But other than that, no impact to the hospital.
Okay,
Can I just ask a follow-up on that, Senator Bradley?
sure.
I know that there was, this is going to be an important issue this session, and I know that there was funding allocated in the last biennium. I don't remember the amount. So I'm just wondering sort of what happened with that and, what needs to happen this session.
Yeah, so we have the 8 million, it's about 8 million. I'm looking at Joe, looking at the CFO, it's about 8 million. And right now we're moving through the process with that money to working with Public Works, working on the partial design, moving towards a bid process. So we're utilizing that for architecture and program planning right now.
Okay. And then
Okay.
the last question was on the PRTF. I know there was a contract out for the PRTF, which is that level of care for children, that subacute level of care for children.
Yep, we're working on it and should have a contract going before Governor and Council in the next couple of months. Again, it's a very complex contract. So even once it's awarded, we can't discuss it until such time it appears on the agenda. But please know that we're full steam ahead.
Okay, sorry to have a hard cutoff. I think we both have preparation via caucuses for tomorrow's session. So Katja and Heather and Joe and everybody else on this call, thanks very much. Continue to reach out to us as we have the last couple of months in the session. I look forward to working with you. Apologies to Kevin and Jim who didn't get a chance to ask questions, but we'll see you